Live stream audio test, 1, 2. Live stream audio test, 1, 2.
Oh wow. We're just going to start. Let me know when we're live. Excellent. Good afternoon, everybody. Welcome to this Health Overview and Scrutiny panel on the 20th of April. It's great to have you all here, and welcome to those of you who are watching online. So this meeting is being live streamed on YouTube. Once the meeting's over, it will take a couple of days to be uploaded for those of you who wish to watch it back. We've got all of the councillors here today and just one person on Teams, and we'll pick up their question as that comes along. So yeah, we've got a bit of a detailed agenda here today, and one of the items we need to make a decision on a substantial variation, so we'll come to that at that point. We did hope to have NHS England here today, but they weren't able to come to talk about dentistry. That will come in June. So if we start on the first item, which is apologies for absence.
Chairman, we've had apologies from councillors Applin, Cherry and Gregor. Councillor Cole, I believe, may be caught up in another meeting, so his apologies also. And Councillor James is online.
Thank you. So next item is public discussion. We don't have any submissions. So next item is there anybody who needs to declare a disclosable pecuniary interest? Oh. So we'll move to the minutes now. So these are the minutes from the 19th of July, 2021, and then an informal panel meeting that was held on the 18th of October. Could I have someone to propose and second those? Thank you, Councillor Hearn, and thank you, Councillor Havison. Everybody in favour of those? Yeah, nodding heads, I'll take that. Excellent. So the next item on the agenda is matters referred by Council. There are none. So that brings us to our first item, which is Healthy Western Phase 2. So this is going to be led by yourself, Colin, and we'll come to you in a moment. But just to say, the way I'm going to do this is we'll let the presentations go all the way through. We'll then do feedback and questions once that's over. And then we'll get to the point around, is it a substantial variation or not? Following that decision, we'll then deal with the other stuff around the evaluation criteria and all that stuff, because they kind of all lead on from that. So I'm going to hand over to you, Colin, if that's okay, to take us through this.
Yes, thank you, Councillor, and thank you very much for accommodating us on your agenda today. For anyone who doesn't know me, I'm Colin Bradbury. I work for the Bristol, North Somerset and South Gloucestershire Clinical Commissioning Group. I'm the Area Director for North Somerset and have been involved in the Healthy Western programme, both Phase 1 and Phase 2 for some time. It's really gratifying today to be able to come today to put forward a set of proposals that have been led by the clinicians and other colleagues to my left, which we hope will describe a positive and really bright future for Western Hospital as part of a drive to integrate with the local community and also work more closely with other local hospitals as part of the ongoing series of improvements and particularly in relation to the recovery from the impact of COVID-19. So I'm going to ask Dr. Hollowood to take you through the slides, which you've had in advance, and then we'll be happy to take any questions or comments.
Thank you very much, Colin. Thank you, Councillor Connolly, for inviting us today to give this talk and take through this process. So for those of you in the Council, I'm Andrew Hollowood. I'm a surgeon by trade, but I'm now the Medical Director in Western General Hospital and have been part and parcel of the Healthy Western process over the past 5 years, representing UHB at that point in time before merging with Western and subsequently becoming, as I say, Medical Director. The team with me to the left are colleagues that if I may, ask them to introduce themselves now so they can take questions later, if I may.
Good afternoon. My name is Mark Ganninan. I'm a Deputy Chief Nurse at University Hospitals Bristol and Western.
Good afternoon. My name is Sarah Jenkins. I am the County Commander for BNSSG, the South Western Ambulance Service.
Thank you. My name's Anne Frampton. I'm a consultant in paediatric emergency medicine at UHBW, but I'm also one of the deputy medical directors at UHBW.
Thank you very much indeed. This process, this proposal that we're going to present today is very much clinically led. It's based on clinical guidelines, standards that we would anticipate to be able to deliver through this proposal, and really drives through a model of care that we feel is of great benefit to Weston, to the surrounding population, and fits within the community itself. We will, however, be focusing significantly on that process in the hospital and the proposal for this through the hospital. Aaron, if I may take the next slide, please. Thank you. So our objectives of today's meeting is really to update you on this proposal that the senior doctors, local clinicians, etc., and clinicians around not just Weston, but Bristol, North Bristol, Somerset have come together to describe as that bright future, as Colin says, a model that is sustainable, that describes a secure future for Weston. We'll set out the proposal and the options for that and how we can deliver it, and describe any changes that we felt may need to be occurring on a sort of daily basis. And then we'll get into those conversations, as you described later, Chair, about whether this would constitute substantial variation or not. If I could take the next slide, please. So this process builds on Healthy Weston 1. Healthy Weston 1 was about delivering a dynamic hospital at the heart of the community. That hasn't gone away. However, the process and the proposal we're about to describe to you is different to that was described previously. We think it provides us with opportunities to provide a sustainable workforce model, a model of innovation, and a model that will describe quality care that can be delivered in Weston as part of its integration with UHBW, with Bristol itself, and the surrounding hospitals beyond. Next slide, please. What I will do, though, is I'm going to put a few things to bed quite quickly. This, as I say, is described through local clinician description. It's described through that modelling, then through the integration process, but it does not affect ED. We propose to keep ED open 14 hours a day, 7 days a week, as it is at this moment in time. There's no proposal to change that. We think that this will offer, the services that I'll come on to will offer a better outcome for patients, that will give a clear and, as I say, sustainable future for Weston in terms of our ability to recruit, to retain our staff. And as we've heard previously in meetings and beyond, Weston is at this moment in time recruiting nurses in a way that is better than the rest of our trust at the moment in time. And through this process, we'll be able to drive further integration with our local community and primary care partners so that we can deliver a seamless healthcare for our patients and ultimately see more patients in Weston through this model that we'll describe. Next slide, please. So using the strategy that has already been developed through council, etc., starting well, living well, aging well, this model of care recognises that we have an increase in builds around the Western area. Increasing build means more families. More families mean children. Children require healthcare mainly through GP practices, and we're strengthening that primary care offer to our local population. It provides, however, the continued 24/7 maternity service at Weston General Hospital. That wouldn't change through this proposal. But we will be thinking about how, or we will be showing you how that we can improve our dedicated service in ED and through the Seashore Unit for paediatrics and provide digital links between the specialist centres and the hospital in Weston so that we can see more patients on the Weston site. With our population, we have more families, more adults. This proposal increases that 24-hour inpatient observation. It improves our same-day emergency care. That means patients who need to be seen for examples of chest pain or breathing problems can be seen earlier in their pathway by senior decision makers, and they can have senior decisions taken about their care that can avoid admission into hospital. We focus on a centre of excellence for surgery. So we can design a model that now can be able to see more patients on the Western site, treat more patients on the Western site. through the options that we're about to describe. And we should also note that we've established and continue through that Healthy Western One process, that Safe Haven Town Centre, so that we can see more patients with mental health crises each week in Western. It builds on that, and we'll describe more. And as we get to that later time of life, this model will describe a community frailty system, a system of enhanced frail elderly care that again we describe as a centre of excellence. What it does is it builds on what is already good in Western. It builds on the GEM service that we already have, that geriatric emergency medicine service. It builds on our work that we've already established with primary and community care partners, such that we're able to keep patients as independent as possible for as long as possible through that seamless passage of care for these patients, able to return them home sooner than one would normally do. Next slide, please. We must note, however, as I've said, that this is one part of a system process. It sits as part of our Healthy Western 2, sits as part of bigger improvement plans around our discharge to assess programme, our ability to get our patients who are that require admission, discharge back to homes sooner, freeing up the bed capacity. We think about how we can manage patients in community for longer with the virtual wards, the hospital at home service, and how the clinical assessment service through 111 can actually see, discuss, have conversations with patients and with our general practitioner staff so that we can again avoid admission into hospital. All of these proposals, along with the integration between UHBW, has allowed us to think about a new model of care. And all of this allows us to address, yes please, with the next slide, the challenges that we have and do recognise. Those challenges of a population that's growing, a population that's getting older, living with longer term conditions, and the inequalities in the healthcare that we recognise. We need to be able to address the challenge of that sustainability, that issue of workforce within Western, and whether we can actually provide a model that will meet the needs of that, and we believe this model will. It provides us with an opportunity to think about new ways of working, innovative models of care that provides different ways of thinking about our workforce so that we can actually improve that quality of care and think about the standards of care that we can deliver. And it really does build on the merger for UHBW. And it's that merger that allows us to think about a new model of care and maintain, as I say, the ED at the forefront of this. And clearly we have to think about the resources as we've come out of this pandemic as to how we best use them in order to deliver the care that we wish to achieve. If I may take the next slide, and I'll concentrate on this a little bit if I may. Within the 12 boxes that you can see there are areas of healthcare that are provided in Western. There are only 3 areas that we're proposing changes in this model. Those 3 areas concentrate on, as described, the same-day emergency care, planned surgery and inpatient medicine. But I want to draw your attention to some of the other areas to really emphasise how that merger, this merger has actually allowed us to think differently. We've been able to have joint appointments in ED between Bristol and Western. We've been able to increase the amount of workforce in Western such that we can now have conversations with HEE who recognise the training in Western is such that people are now attracted to coming and working there. That means that ED can function and remain in Western as it is. We can continue with receiving ambulances as described. The emergency surgical patient, the emergency fracture patient, this will not affect the admission of these patients through this modelling. We can still continue to deliver that activity. And one of our intensive care unit, or the intensive care unit now is actually staffed through joint appointments of consultants, both from Bristol and Western, who have joint appointments on both sides. Again, with the digital links, it means that we can improve the quality of care within that and provide a robust modelling, a robust rota to deliver the care that we want. All of these areas, while not affected through this process, continue to be developed through the model of integration that we have. And on the back of that, we can think about how we can improve things. And that improvement comes through the same-day emergency care as the first and foremost. So if we can have senior decision makers, consultants, at the beginning of a patient pathway, and for a patient that may mean a patient who presents with chest pain, with shortness of breath, with, for instance, as we described before, patients who have headaches or even a pulmonary embolus, a clot on the lungs. Patients who arrive can be seen early on in their pathway. And if they're seen and have their investigations done early we can actually risk stratify. We can decide which patients need to be admitted and which patients can be managed at home. And that means we can avoid admission into hospital. And we do know that over 30% of our patients reside in hospital for 1 day, 0 to 1 day. We can actually think about how we can improve that care for you. This model does that. This model allows us to think about more operations occurring on the Western site. So we can think about how we can provide more inpatient activity on Western site, while at the same time increasing our day case activity in the conditions and the areas that are described there. Aaron, if I may have the next slide. That allows us to think about using the capacity of those changes, as I say, to think about whether we could see more patients who are having to travel further, whether more patients who are suffering at this moment in time with pain around hips, knees, joints, etc., can have their surgery on site. And we do that by transferring those patients who need specialist inpatient medical care to specialist inpatient medical care units. So should you need heart problems, respiratory, breathing problems, or a GI problem, a medical problem, those patients transferred to an alternative provider allows us to do everything that we're describing here. If I may take the next slide. The clinicians themselves came up with two options around the front door, around the emergency department. And that was to suggest whether we would have any patient who arrived in an ambulance who was not frail would in option 1 bypass Western, would go directly to another hospital where they would be seen, triaged, treated, and if need be, admitted to that specialist unit. That would amount to about 6,000 ambulances each year travelling outside of Western. But it would mean those patients who require admission to hospital would be admitted to that specialist unit there and then. The option 2 was that we would have all ambulances arriving in Western, where we would see you, triage you, treat you, and admit for 24 hours or so before discharging or sending on to an alternative hospital if you needed onward admission for your care. That was related purely to those medical patients as I've described in the slide before, not relating to the care of the elderly patient or the surgical patient. That, we feel, is a favoured option from the clinical teams because it allows us to treat more patients in Western, it reduces ambulance journeys, and it keeps ambulances in North Somerset. It reduces the number of emergency patient beds that are sent to alternative providers, so they're non-elective, the emergency patients to there. And we feel it provides Western a better opportunity to recruit to a fully functioning emergency department than it would in option 1. That we still need to go through that evaluation, and that is going on, but that is the favoured option as described at the moment in time. If I could take the next slide. And this really explains the changes that then would occur from that. So currently we see 137 admissions or attendances per day in Western. In option 2, that would remain. All of the ambulances arriving. We still see in the option 1 a number of patients travelling to other providers for their onward care. In option 2, there's a few more. That's 8 extra patients that would need to travel. 8 patients actually equates to 5% of our ED admissions. But what it does do, it allows us to see somewhere between 22 and 114, we can explain that later, extra procedures that could occur in Western. Patients who already travel outside of our catchment area to alternative providers to seek care in terms of their operations, surgical procedures, etc. So by the transfer of a smaller proportion, we can see far more patients in Western. If I could take the next slide. Clearly, travel is a big issue, and we do recognise this as one of those issues that would be affecting individuals from Western. We recognise our population of patients and the searching for healthcare is what they require rather than thinking about the need to travel and cost of. What we do recognise also, though, is that in this proposal, more patients would be seen in Weston than are currently. By bringing those planned operations back into Weston, it would mean that more patients would be treated locally and we wouldn't need to travel. And with our recognition that the onward need for the planned care procedures, which is it's going to take a long time to recover from, we'll be able to deliver that care and at the same time think about how Weston can contribute to other providers, to other areas in order to deliver the care it is. And we put in an example there of patients with cataracts, patients who require eye surgery, often having to travel 4 to 5 times in order to get into Bristol to have their care, whether they're seen in outpatients, have their pre-op assessment, seen to have their surgery, their follow-up, etc. Significant number of travel occurs per case for our patients in Weston. That activity, that operation can occur in Weston. We also recognise that by doing this, the most life-threatening emergencies, which already go to Weston, which would ever go, would be treated in the specialist centre. By doing so, patients have a shorter length of stay. And we need to really think about how we can accommodate carers, accommodate our patients, but also our family members in order to visit, and how we can actually think about the digital environment so we can actually have patients being able to see their family members at any point in time through alternative opportunities. So it's something that we've thought long and hard about, and something that we do need to address and will continue to address as we go through this process. But if I could take the summary slide, please. This process, this proposal that we put before you today, allows our emergency and accident and emergency department to remain the same. It allows the same number of walk-ins, the same number of ambulances in option 2 to continue. It allows us to recruit, we believe, to that fully functioning ED and strengthen what is already a service that has been strengthened over the past 2 to 3 years. I want to make that point that there's no changes to 9 of the 12 key areas in Western General Hospital, over and above the service improvements that are already ongoing, over and above what we're already doing in order to strengthen and build upon that integration that we've already got going on. It expands our same-day emergency care, our planned care service, so that we can see more patients. We can start to deliver on the backlog that we've seen build over these past few years. And it would mean that 8 additional patients would have to travel for their specialist care, but in doing so, that specialist care will deliver better outcome and it will shorten the length of stay for our patients. Those patients can be repatriated back. And in turn, as I say there, we will see somewhere between 22 and 114 extra surgical procedures on site through this proposal, through the creation of that specialist centre, that centre of excellence for surgery and training. I thank you for that and leave you with that next slide, which describes, as Councillor Cronley has described, whether we consider the options at the end to be substantial variation or not. Thank you for your time and listening. I'm very happy to take questions.
Thank you, Andrew. So I'm going to open up for questions. Councillor Parker's being quick, so you go first.
Thank you, Dr. Holloway, for that very concise report. And as you know, councillors have received a similar report earlier, as have members of the public. And like me, being an ordinary sort of person, members of the public probably have questions as to, what does that actually mean? So I'm going to ask you, if you don't mind, 4 particular questions, and if you could answer those in plain English, rather than your unusual medical jargon, I think that would be helpful to us all. So my first question is regarding inpatient medicine. What types of inpatient care are we referring to, and why, if more than 24 hours care is needed, does the patient need to be transferred to another hospital?
Thank you very much, and I'll try my hardest. So inpatient medicine, we're describing patients who require or have, say, heart problems. So it may well be heart attack. It may well be need for ongoing treatment of things like that, or a significant respiratory, a problem with your breathing. It may be certain patients who have, say, pulmonary embolus, which is a clot on the lungs that need treatment and ongoing treatment for care. It may be patients who have a liver failure, so the liver failing for certain conditions, or, for example, a complex GI, so gastrointestinal, a gut problem, where you get problems with, say, inflammation of the bowel that need ongoing treatment in specialist units. We know that specialist units have better outcomes in that, not because of the individual clinician necessarily, but because of the surrounding nursing staff, the treatment options, intensive cares, etc. And transfer of those patients would be the patients we're describing. The reason that we think about 24 hours and beyond that is the 24-hour period allows us to review the acutely unwell medical patient, to be able to make a senior decision early in their process and think about transfer appropriately to appropriate decision makers, appropriate treatment to appropriate clinicians and teams. And we also know, as I alluded to, that a significant number of people, over a third of patients in hospital, just reside in hospital for around 0 to 1 day. And so rather than transferring all patients to another hospital to be admitted and then discharged after a day, we can see, treat and discharge patients back to their home so they're not having to travel to an alternative hospital.
Okay, that's fine, thank you. My next question then is your ambition of developing a surgical centre of excellence, which sounds very good, of course, but it is subject to capital investment. So my question is, what happens if you don't get the money?
Yes, thank you. So the ranges described there describes that, in that we know at the moment through the theatres that we have, there is at least 27 beds worth of activity. So that's patients who we can see, we can treat through the facility that we have at this moment in time. We also, as you will have seen through the paperwork, we have submitted for investment into additional theatres on the western site, an additional investment that would allow us to do far more of that activity. And we are very cognizant that there will be further funding streams that will be available to be invested or to bid for as the recovery following COVID will continue for at least, we would anticipate 3 to 5 and possibly longer years.
Okay, thank you. Significantly more people than now would be able to receive planned operations and procedures at Western General Hospital. So again, in layman's terms, what types of ops and procedures are we referring to here?
So we would focus on those areas that we already treat patients at the moment. So those areas would be some of the eye surgery, hips, joints, continue with the cancer surgery that we do in terms of breast, some of the urological surgery, and the GI, so again, the gut, large bowel, etc. We would continue with the emergency surgery as described in this proposal, and we would look to expand those areas. We're having conversations and have had long discussions with North Bristol about enhancing and improving and bringing more patients for the urology, the waterworks side of things. So more of those patients can be operated on, and again, some of the gynecological procedures as well. So if we concentrate on the day case, we can do more of our patients, but we're also thinking about the inpatient activity as well in those areas that we already perform in. Thank you.
And my last question then is, you're looking to establish a centre of excellence for older people. So at what age does one qualify for that?
So it's a very good question. There are two ways of judging that in terms of age itself or in terms of frailty scores. The modelling and the working that we have worked on has been an age of 75, but we also recognise that as we age, we think about ageing well from the age of 50 onwards, but we also recognise that individuals below the age of 75 have frail needs because of ongoing comorbidities, their other complications and the other conditions that they have. And so it's slightly complicated in terms of how you would judge it, but from an age cut-off, we are considering patients here from 75 and above through this modelling, but we would also consider a referral from general practitioners according to frailty score and need of patient.
Councillor Ross-Willis.
Thank you for that. So a question at the moment for me to start with is how much of this option 2 can be achieved without that capital investment? How much is the need for the capital investment to achieve what you've stated so far?
Excuse me, in terms of the theatre, the estimate, as I've said, is approximately 27 beds worth of activity. Now, that would allow us to think about the day case surgery, but also the inpatient activity. There's a significant amount of activity that can occur through that process. But in order to achieve the remaining of looking for additional 2 theatres, that would allow us to continue up to the number of patients described of over 100 per day, additional patients. Colin, do you want to?
Yes, so I'd say a little bit more on that, on the explanation of the capital and where from and how it's achieved. So is it achieved by selling the services to other hospitals to pay, or how is that achieved? So is it clarity for anyone listening in?
Yeah, certainly. So just to be clear as well, that not all of the proposals that Andy's outlined require on the capital. It's specifically around the surgical hub and extending the surgical capacity. Things like the same-day emergency care and the changes to inpatient medicine to improve outcomes and reduce length of stay, that can be done without any capital investment of this nature. The potential we've got for Western to become a surgical hub and a surgical centre of excellence, I think, is really quite exciting. What we're saying, I think, is, put crudely, about a third of the potential we can realise already without any capital, and then the remainder of that would require further capital investment. There are 2 main sources for capital money within NHS. One is allocations from a national source, and the other one is we have local capital funds available as well, which obviously we have to think about in the round for the whole of the Bristol, North Somerset and South Gloucestershire area. Of course, post-COVID, as we sort of progress out of that initial first phase of COVID, there is still some work to do to get our capital programme back onto a more even keel. I think what we would be able to say to the panel today is that we've had very positive conversations with our regulators, NHS England, and with our capital allocations team about the possibility of consideration of bids for funding. Those conversations aren't finished, they're not landed yet, but they are in progress. So we're confident that more capital money will become available. What I can't say with any exactitude today is exactly when or where that will happen, but we think we're very well placed within the BNSSG system to attract more capital as this programme rolls out as proposed.
So on my list I've got Councillor Bell, Councillor Havison and then Georgie Bigg. So Councillor Bell.
Thanks, Kieran. I've just got a few questions and a couple of comments, really, on the proposal. So I think in broad terms, there's, clearly been a very good, strong narrative that underpins the Healthy Western 2 proposal. So I really welcome that. I think it's been very, very clearly communicated what the ambition is, what the detail of the proposed changes are. I think what I would be thinking if I was and I am, a resident in this area is, what does this really tell us about the long-term future for the hospital, and what assurances do I need, both as an elected councillor and as a resident, as a parent in our area, about what this means for the hospital? So I think, for example, that it's a little bit naughty to say, well, there's no changes to ED, for example, because in reality there are changes to ED, aren't there? In the sense that if I arrive there under these proposals in the future, I might well be transferred somewhere else in a way that I'm not now. So my experience of going to the emergency department will be different in the future. So I think it's a little bit misleading to say that there's no changes. And I do think that the packaging up of the proposals is interesting as well, because clearly the benefits are largely in the planned surgery area. Great, they sound really good and exciting, and I agree with you, Colin, they do sound exciting. Why can't we do those anyway? Would be my challenge, because actually that's about treating more people locally here in Weston appropriately. So it feels to me like a no-brainer, get on with it. Why has that got to be attached to the wider changes around emergency care, around inpatients, and so on? But I suppose my biggest concern, so if there's any comments on any of those points, that would be interesting. But I suppose my biggest question is about what does it tell us about the long-term direction for the hospital? Because I think to myself, we're already in North Somerset a population in excess of 200,000 people. We know that that's going to grow significantly over the next 20 or 30 years. So how do these proposals help to deliver an acute general hospital for North Somerset, because that's what it is, and indeed not just North Somerset, but also parts of northern Somerset as well over the border? How does it help us to deliver the kinds of services that the mixed community in Western and North Somerset are going to need over a longer period? Because it definitely feels like a set of proposals that help to tackle the challenges today. And I absolutely applaud that, but I'm not sure that I understand how it helps to advance and meet the needs of the community in the longer term. It doesn't, for example, talk very much about how we're going to improve primary care and community care services, which we know is a significant weakness in Western. We've got a real postcode lottery in terms of experience of primary care. Your presentation talked about the new practice being built at Parklands, which is great, but of course that is about serving a new population that is developing in the future. It's not about how to meet the needs of the existing population. And I think particularly on the emergency department, I would be interested to know why, you asserted in your presentation it's going to help us to support recruitment and retention. And I'd be interested to know why you think that is, because actually you are going to have a lesser, not greater range of patient types going through ED in the future under this proposal. So I'd just be interested to know why is that going to help you to change that dynamic? Because I think that's an area as a resident I want assurances on. I want to feel we've come this far and no further in terms of ED, and indeed many colleagues would say we need to go back to a 24/7 service. So I would like to understand how these proposals are going to help to influence that. So really, a couple of detailed things, that big long-term picture, how does it move us forward, and then what assurances can you give me that in terms of the emergency department particularly, this strengthens things and doesn't further diminish them?
Thank you very much, and thank you for your comments. I would take issue with the fact that we're talking about ED and we're misleading. For any resident of Weston to access ED in option 2, and that, sorry, Colin, may I ask you, sorry, just so I can see you to actually have that conversation, so I do apologise. You would access ED or you would access healthcare in exactly the same way as you would now, either through your general practitioner or through 111. Attendance at ED would be exactly the same under proposal 2, or an option 2 as it is at this moment in time. Your stay in ED may well be quicker, better, because of our ability to recruit and the ability to see patients. And I'm going to ask Anne, if I may, who's an ED consultant, to really build on why we think that recruitment and retention would be better under option 2. Most ED admissions, though, should last no longer than 4 hours. Now, we clearly know that they last a lot longer at this moment in time before you then are sent either into the hospital. So your period of time in ED should be exactly the same as it is at the moment under Proposal 2. Your stay and longer-term stay in the hospital may well be different. You're quite right in that you may then be subsequently transferred either into the hospital or onto an alternative hospital after that point. But your journey through ED should be the same. What will be different is your ability to access the same-day emergency care facility that is proposed in this proposal, the ability to access senior decision makers in terms of the medical consultants, the surgical consultants, so that you get a quicker access to the senior decision and then actually can get your discharge back out into community quicker. So what we think we're proposing here, and what we believe we're proposing, is a similar model to terms of ED, and your ED pathway, but a model that allows you, the senior decision maker, in conjunction with that same-day emergency ambulatory care, to provide you with a senior decision and discharge back out into community quicker. Transfer into the hospital, I would agree with you, differs. If I may, at this point, I'll just ask Anne to really go into a little bit deeper the model of why recruitment and retention is better before I then come on to the benefits you described.
All right, thank you. Yeah, so as Andy says, I'm an ED consultant. I actually work just in the Bristol Children's Hospital now, but I am trained as an adult and paediatric emergency department consultant, and I've worked as an ED consultant for 16 and a bit years. So I absolutely accept, I think we would all agree that the proposal, in the option 1 part of the proposal, we think would be a risk to recruitment and retention, because for exactly the reason you describe, which is that there would be a significant over time decrease in the breadth of presentations that came to the emergency department, and you'd see natural drift with that, even if we didn't actively do that. But in option 2, the option 2 of the proposal, I think is different. So we would intend in that option for people to continue to attend the emergency department. We wouldn't divert any patients away from the ED at Weston that aren't already diverted because of major networks already. So we know that there's a stroke network, there's a major trauma network, there's a cardiac network. Those patients don't come to Weston, they don't come to lots of other DGHs either. So that's no different from working in any DGH. I think the thing that's different about this proposal now for Weston are 2 things really. So firstly, it gives Weston, it gives it that kind of sense that it has got a future. So I think a lot of the problems around recruitment and retention in the past have been because it's not clear what might happen to Weston. There's always a bit of nervousness. What's going to happen? Is Weston going to stay the same? Is it going to, what sort of type of patients will we see there? How's that going to work? What's the future for Weston? And so by giving Weston a really clear direction and future, that makes it a lot more recruitable too, and much more attractive. And then the second thing is that actually what we're proposing here is something that I think is very attractive as an emergency department consultant. So when people who do emergency medicine, on the whole, what they like to do is they like to take patients who present with symptoms and work out what's going on with them, and then work out a diagnosis and work out what the onward pathway for that patient is. And that's what we're good at, and that's what we enjoy doing. And it's a very broad specialty, and some people love doing resus, some people love doing major trauma, some people love doing the pre-hospital stuff. But at the core of it is taking patients who don't have a diagnosis, working out what's going on, and getting them to the right place and the right care that they need. And that's what this proposal in Weston does, because it gives the emergency department much better access to investigations early on in the journey. So you're not just seeing people and then admitting them to hospital so somebody else can diagnose them and have investigations. It's the front door, as it's described as an enhanced front door, works with acute medics, and it works with the geriatric emergency medicine service. And we know that the geriatric emergency service that already exists in Weston, and which we think we need to grow, is already recognised nationally as a new way forward, and a way forward that we want to go to. And by working sort of in conjunction with those, what you do is you create a model that's actually really attractive, particularly for consultants and for all sorts of grades of staff. So not just medical staff, but for ECPs, EMPs, other members of staff who like seeing general patients and like seeing that breadth. If you want to be a consultant in a major trauma centre and you are and that is your be-all and end-all, Weston's not the place for you, but it never was and it never will be. But in what Weston offers is for people who really enjoy seeing, stuff that comes through all emergency departments every day, that, you know, a real breadth of experience of stuff. And I think that we can offer that, we can offer it in a new and innovative way, we can offer it in conjunction with, like I say, the geriatric service, emergency medicine service, in conjunction with the acute medics, and you can make that so that your experience, that's, you know, that's a much more satisfying job than working somewhere where you just see triage people and admit them into hospital. And so I think that does make it much more sustainable. We're starting to see that. We're starting to see more people applying for our consultant jobs when they come out, and that's a really nice thing to see. We're starting to see people wanting to stay in Western. And I think if we can build on that, then, you know, it doesn't take much for then that to sort of start to then be a sort of snowball effect, and you get a really good engagement with it. So I think, I don't know if that answers all of that question, but I think that's where I'd go with that.
Yeah, yes, it absolutely does. And so essentially what you're saying is that certainly from the professional's point of view, the fact that some people might arrive, be assessed and then be sent on, because we know from your figures that there is an expectation some people that will be true of. The fact that the assessment and the treatment might then say, actually, you're going to need a prolonged stay in hospital, so then you're going to be sent somewhere else. That in itself, from a professional point of view, doesn't impact on people's experience. Okay, so that's really, really helpful. I should have asked, actually, and I forgot to, just in respect of that, do we have anything about patient outcomes? Because obviously you implied that it was probably better for people, and we do know that specialist care is generally better anyway. But I'm just wondering about the difference between option 1 and 2, the delay that inevitably will occur if people go into ED, are assessed, then are deemed to need to be referred somewhere else, and then off they go. How does that balance out in terms of patient outcomes?
If I may take that first, and I may well ask Sarah to comment, and then Colin wanted to come back in. So in option 1, you're quite right, there would be 6,000 people who would go directly from their home or wherever, picked up in an ambulance and conveyed to an alternative hospital. That would impact in terms of ambulance conveyance out of our region, and it would also mean that individuals would be on the end of a queue at some point in alternative providers. In option 2, what we're describing is a transport team, an in-house transport team in Western. So patients who come in, who are seen, who are triaged and treated for that period of time, you then get transferred via a planned transport through our own transport team to an inpatient ward. So you're not actually adding them to the back of a queue, because we recognise that that would be poor care and poor patient experience. So that can't exist either. So in the proposals, we've also documented as to how that would affect the ambulance service itself. And if I may I ask Sarah to come in at this point to give the SWAS version, the view of that.
Yeah, thank you, Andrew. So as Andrew has explained, under option 1, from an ambulance service point of view, it would mean we would be moving out of the area more frequently. So routinely taking patients to other destinations, whether that would be Musgrove, BRI, Southmead, therefore depleting the resources and the available ambulances that we have in the North Somerset area. So we have ambulances in Nelsey, Weston and Churchill, and they're here for a reason. They're here so that we can provide the service to answer the 999 calls to the North Somerset community. Under option 2, the impact on us is minimal. We still continue to convey patients to Western General ED, as we do already. There may be a need for an occasional patient that needs to go elsewhere. If that's under emergency conditions, we will, of course, do the right thing for the patient. If we need to go to Western General in the first instance to provide some stability and some life-saving interventions before we then onward transfer, under emergency conditions, we will always do that. If it's not a life-threatening situation and we take to Western General, we leave, we've still got our available ambulance in the North Somerset area, any onward transfer, that's where it would be picked up by a patient transport type of service. So the impact to us as SWAST is minimal under option 2 and allows us just to continue to provide the service that we're already providing for North Somerset.
Thank you. May I ask Colin to comment?
And just to pick up a couple of, sweep up a couple of extra points, if I may, Councillor. So You say about the long-term direction of the hospital, and I do think that this gives Western a really clear sort of description of how it serves the local community, both in terms of integration with local partners such as primary and community services and mental health services, but also within the wider hospital system. So we integrate in different ways, horizontally and vertically, if I can put it like that. And as Anne has already alluded to, I think one of the main challenges that Western Hospital has faced in terms of recruitment and retention of staff is certainty about the long-term future, which this will give it. Focusing on population need, both in terms of strengthening of paediatrics, which we can talk more about, and also in relation to specialist care of the elderly treatment. In relation to primary care and other services in the community, very happy to talk about that in more detail, and we've made good progress in some areas. There's still more to do. You may be aware of a service led by Peer Health that's recruited a whole new team of GPs and nurses and other healthcare practitioners to our community frailty and care home service, which will integrate very closely in the new model. Recruiting a service like that, because it's a new service, it's an additionality. We wouldn't normally seek to get advice on consultation because it's extra and it's a sort of additional change rather than just moving a more substantial variation of existing services. So it's not subject to the remit of Healthy Western Phase 2. And then very finally, you asked about, I think, why can't we do the surgery stuff anyway? As has already been mentioned by my clinical colleagues, the proposals don't touch the A&E, but they do propose some changes to the inpatient bed model. So by making those changes to the inpatient bed model, as Andy said, which would affect around 5 or 6% of A&E attendances who need to go into hospital for a specialist medical service, what that does is frees up actually a material number of beds that can then be free for surgical patients, and that's what unlocks the potential for the surgical hub, because otherwise there's not the bed capacity to treat the additional patients to the scale that we have an ambition for. And I think the very final thing I'll say, if I may, if you'll allow me, is just you may well be aware already, but as part of our pre-engagement work, we did an online public survey of the proposals, with around 900 responses. A very large proportion of those were from NHS staff and therefore people working at Western Hospital, which were very supportive of the proposals, I think, and that chimes with Andy and colleagues' view about the staff engagement they've been doing. I think that there is a real sense of momentum with these proposals, and people can see how they would fit into a future model within Western, which would help with that ongoing recruitment and retention challenge.
May I just, on the end of that, and thank you, no, we're getting quite passionate about this, because I think what it tells us is that there is a future for Western, and a sustainable future for Western that we can be excited about. I think what we're trying to describe here is an ability, and Colin's mentioned the word about that integration with community, with primary care colleagues, so that we can deliver that front door ED and maintain it on site. We are very conscious of the build, the development in Western, the bulge in, the fact that Western is growing as a population, and that population needs to be served. This is about maintaining that and actually building on that. It's about building on the integration that we've got with UH Bristol as well. And what I wanted to emphasise there in terms of a critical care is that my critical care is maintained, but it's maintained with the workforce, the consultant workforce that's across both sides. We continue to build on that. It allows us with the Seashore unit to expand, to increase our activity so more patients, more children can be seen on site. We want to prevent people travelling to have and reach their care. But when you do need to go, you are going for a reason, and you're going for the specialist care, which reduces your length of stay and improves your quality of care so that you can return to your loved ones sooner. But we also want to be able to see that we operate on more patients in Western, but also then allow Western to contribute to the system as a whole. Because if we can start to attract the services that create that specialist centre, then we can start to deliver the care for the populations beyond Western as well. So Western not only secures itself in community, it secures itself in terms of UHBW, but it secures itself a future for an opportunity to deliver care for the surrounding network as well. This is what the future of Western can be and should be as we move it forward.
Thank you. I'm going to hand over to Councillor Havison, but just say, is there any questions from Councillor Hugh James online as well? No, cool. Councillor Havison.
As I understand it, the whole system of changes involves a much more intensive triage system right at the beginning of the patient journey. That's clearly very positive, but what does worry me is how much of that change would involve a redeployment of existing staff and existing supporting facilities such as X-ray and laboratories, etc., because it has impacts on things we probably don't immediately think about. How much would be redeployment and how much would we actually need to fund with capital investment?
Thank you very much. I'll take the second part of that question, if I may, and then I will hand over to Mark to talk about the nursing staff, the requirement in terms of workforce therapy staff. So we have part of this proposal looked at in the terms of what is required for investment in radiology, in lab-based medicine, etc. Because clearly, if you're going to have senior decision makers, you want to have the diagnostics at that point as well. Western already has 2 CT scanners, and we've recently got another CT scanner on board in Western. We have an MRI, and we have opportunities to expand into community diagnostic hubs in order to deliver the X-ray facility and have that infrastructure already. But we have been looking at how we would need to resource that in terms of consultant and radiology staff in order to provide that. That's part and parcel of this proposal and part and parcel of the workforce model, along with looking at when and where you would need to have the lab-based medicine in order to complement the number of patients who are seen and when they are seen as part of this. So that is work that is ongoing at this moment in time, but the workforce model around the radiology already on board there. In terms of the additional workforce that we would need to support all of these, I'll ask Mark, if I may, who may well want to contribute in terms of what this model also provides from the last point, but also in terms of therapy staff and how we manage.
Thank you. So from the nursing workforce perspective, there's very little change required for this, for the option 2, as that we're sort of discussing mainly at the moment. So the workforce is essentially there already. The establishment and the funding is in place, and there is no material change to the whole-time equivalents across for the core nursing workforce. The areas that will change a bit will be the advanced practitioner roles and the consultant practitioner roles that we would bring in to enhance the assessment abilities at the front, especially at the front door, but also further back into the hospital, where these roles will support the medical workforce as well in terms of speeding up decision making and therefore the flow through the hospital. The therapy workforce will require some further input, and we do have some challenges around, to be honest, with the therapy workforce. We've tested that in terms of our medically stable for discharge wards. So these are patients who are medically fit, do not need to be in the hospital, and are awaiting different packages of care to get them either back into their home, wherever that home may be. What we feel quite strongly, though, is that by developing these proposals, is that it accentuates and extends the unique selling point, really, for Western. Western historically has had challenges in recruiting and maintaining staff. We've been able to do quite a bit of work in the 12 months that I've been in Western, and in that period of time, we have decreased the nursing turnover. So we're now at just over 10%, whereas the trust average is running at 17 to 18%. So we're the best performing part of the trust. And we've had a net increase of 15 registered nurses in the last 9 months. So we're not only starting to maintain better, but we're also recruiting. And we're doing that with what we've got available to us at the moment, which is work-life balance, changing the narrative around the trust, and so that we are telling a more positive story. Once we can describe the model going forward, we then have something more concrete to actually hang a selling point on, that we can market, that we can attract staff to. So what we've talked about with the ED model at the front door and enhancing that, the geriatric emergency medicine, and the different areas behind that front door in terms of the pathways as well as the inpatient areas and the new roles, then we feel very strongly, I feel very strongly, that we can actually attract staff, because we have had feedback from NHSEI that what we are proposing is quite innovative and it isn't replicated in many places across England. So we have great designs to be, at the forefront of a lot of the care, and especially from a district hospital perspective. So I think we've already made some progress with the tools that are available to us, but by being able to take this trust further and further enhance the offering to the local community, we feel very strongly that we'll be able to attract professionals not only to work but also potentially live and make their homes in Weston as well.
We're going to go press a button there, were you? All right. So, Georgie.
Good afternoon, and I think I ought to introduce myself because I don't have a nameplate. I'm Georgie Bigg, I'm the Chair of Healthwatch BNSSG, and I'm a co-opted member of the panel. I think some of the questions that I have been touched on already, but slightly different angles to them. So I'd like to start with the calculations that you might have done on capacity going forward, because the last 2 years obviously have been different times for Weston-super-Mare in terms of visitors, and you can see the difference today with the volume of people there, and obviously some of those might come to use the hospital. So what sort of factoring has been done to anticipate that, not just the growth in population, but that extra hit that you get during the summer, particularly with visitors?
So you're absolutely right, Georgie, and it's a challenge for all NHS planning at the moment, because obviously the last 2 years' worth of hospital or any sort of healthcare data are unique, really. So, we had periods during lockdown where there was very minimal presentations, and then there were periods where there was huge spikes in presentations. So for that reason, and that's standard practice across the service, we've used 1920 as a baseline. So we've used the last year of full data, obviously compensating for demographic growth in the meantime, but we've used 1920 because that's the last year of available data that would have anything like a sort of usual demand pattern within it.
Right. The second one I have is relating to the 24-hour assessment. Could you confirm whether or not that's similar to the Bristol type of 24-hour assessment, which I've experienced in the last few months?
I'm going to ask Anne, if I may, who's well versed in that.
Thanks. Hi there. So similar but not quite the same. So I don't know if it was North Bristol or the BRI that you visited. BRI. Yeah, so the way that, acute medicine in its sort of purest term, acute medicine usually takes acute admissions up to 72 hours. So we're not planning on proposing that for Weston. This is 24 hours, and it's the proposal for Weston is a sort of hybrid unit. So within most emergency departments will have what we call an observation unit, where patients who definitely don't need ongoing inpatient admission, but who need a period of observation beyond the 4 hours that you're supposed to stay in the emergency department can stay. Weston doesn't have that at the moment, and that I think is something that we definitely could improve on, because we know there are patients at the moment who will then get admitted under medical specialties who then have a very exaggerated length of stay because actually they're being admitted and on an admissions pathway. From an acute medicine point of view, therefore, in Weston, what we're proposing is a hybrid unit with those patients who have an ultra-short length of stay, but longer than 4 hours, and patients who need a length of time in order to differentiate them, in order to make sure they're on the right pathway, that they go to the right specialty, that they have the right set of investigations to do that, so that you're not being transferred, you know, unnecessarily, but not as long as the 72 hours that you would get in most sort of traditional acute medical units. And the reason for that really is around the level of staffing that you would need to do for that, the increased sort of need for specialist input on site that you'd need for that. So once because if you started to go beyond 24 hours, then it begs the question, well, if we're going beyond 24 hours, why aren't we admitting those patients and keeping them in Weston? And we don't think that in our proposals, we don't think that's the right thing to do, because of the way that, because of the size of Weston, and because of the other things we've talked about in terms of recruitment of specialties, and, you know, not having lots of small pockets of specialties in one hospital, but getting you to a centre of excellence. So yes, very similar, but with a slightly shorter length of stay than you might have if you're in Bristol.
Thank you. That's interesting, because I only knew I was in 24-hour assessment when I saw the sign on the wall.
So it may have been the observation part then, rather than the acute medical unit, which would have a slightly longer one.
Yeah, I wouldn't know. Thank you. It was all fine. All fine. I can give you a detailed brief later. My next one was about the theatres, because you've talked about, you know, increasing the availability of planned operations. How many theatres are there at the moment?
Excuse me, we have 6 theatres. 4 are used for inpatient activity and emergency work, and they have what we call laminar flow. So they have an ability to have hip replacements, joints, etc., operated on because of the ability to extract the air so we don't incur infections in joints. And then we have 2 day case theatres that are separate to those, and they're supplemented by the 5 intensive care HDU beds that we have that sit in between them. So there's a day case area with 2 day case and 4 other theatres.
It's just that I was trying to work out your numbers here if you had the investment. So there's some very big numbers on hip operations and on cataracts, which you've mentioned previously. So how many theatres would you need to provide those?
So the addition of 2 theatres running for that period of time would allow us to continue with that activity. You have to bear in mind that the number of cases you can do on a list. So the activity that you can, there's a national programme called GIRFT, Getting It Right First Time, describes the number of operations that should occur on each of those theatre lists. And one of the suggestions is up to 10 patients with cataracts being operated on a single list. So the day case activity allows us to do a significant number of patients through those theatre complexes, as opposed to, say, a hip replacement or a cancer operation that you may well only do 1 or possibly 2 cases on a single list themselves, which is why you get that variation dependent on the type of cases, the case mix, the type of surgery that you would perform through those theatres.
Okay, so say a theatre that did hip replacements, how many hip replacements would you normally do a day in one of those?
2 to 4, dependent on the type complexity of the case itself.
2 to 4.
In a day.
Okay. I just thought those numbers looked a bit large, but maybe my calculations are wrong. The other item which you have mentioned was around the support to people outside hospital, you know, that transition from hospital to the community. And, you know, obviously everyone has to work together to make that work, because Weston can't work on its own, can it? It needs the support of a good discharge to supportive care in the community, whatever it might be. So how much do you see in this that forms part of it? I know there's a reference to peer health, and there's a reference to frail elderly and so on, and the specialist teams coming in there. But if you're you know, not everyone who has an operation will be frail elderly. So what areas of work are happening to support those?
You're quite right in terms of patients who have surgery, but patients who have frail elderly needs will need different types of support and care. What I will do is I'm going to ask Mark to comment on the work that we've already done with Sirona and the work that's ongoing with the community hub, because Western, I think, is that we've already been able to break down those barriers. We've already got an awful lot of work that's ongoing at the moment in time to support those patients' needs. And that has allowed us to explore other ways of recruiting and actually delivering the care and support. Mark, do you want to talk about what we have done so far?
Yeah, thanks. Yeah, this is a particular passionate area for me. We've very much approached this as a system. So very early on, we agreed, we being the collective as in UHBW and Sirona and primary care, that we would remove the organisational boundaries. So the NHS historically has, when you're looking at pathway development, you've got a hospital does their bit, community does their bit, primary care does their bit. And what we agreed very early on was that we would just look at the patient pathway and what was right for the patient and their family. And by doing that, we have very quickly reached the point where we have blurred boundaries. So already in one of the projects within the hospital, the medically fit for discharge ward, we have Sirona, the Integrated Community Care Bureau representatives on site on the ward. They have Sirona employees, and we also have representatives from the local authority on site on the ward, helping to sort of streamline that discharge process and decrease the length of stay. So going forward, we would look to be working further on that in relation to continuing to blur that boundary. So hospital staff potentially going out and supporting community colleagues at the back door, so helping to facilitate earlier, smoother discharge, but also at the front door. So the geriatric emergency medicine, what we're looking to develop and exploring with Sirona is what we can do to work together for admission avoidance. So working once again with the ambulance services as well, and how we can work together to keep people in their homes. So that's what, you know, I think the emphasis there is, what I'm saying is that collaborative working. What you've talked about there is that, you know, that smoothness. Does that sort of answer that question?
That's great to hear, because it's the main thing that concerns the population at large and everyone who uses the service, and that's falling between them.
Yeah.
You know, and trying to get from one to the other. And actually, it should be that they don't even notice they've moved.
Exactly. We've got some of the advanced practice roles. We're looking at other joint contracts, but it's certainly in terms of job plans where they'll be spending time not only, so the advanced clinical practitioners, not only spending time within the hospital, working on the wards, working as part of the medical workforce, but we're also looking at how they can work within the community and within primary care as part of the frailty hub that is run through Peer Health. So those practitioners adds a lot of variety, and this comes back to the unique selling point. We feel that if we can offer these innovative, varied roles that people can get skilled up in a variety of areas, that is going to be attractive to a large number of people. Some people would prefer to be very, very specialised, but by and large, I think in the NHS now, and with the younger generation especially, we're seeing that they're a very mobile population, and they don't like to be stuck in one place. They like to move around, and that's why rotational programs are really important, and that comes back to, once again, future-proofing the hospital and the system, because the young nurses and therapists as we have at the moment, this very mobile population, in a few years will be the experienced senior practitioners. So by future-proofing the system and having that ability, we will be offering them what they want later on in their career.
Yes, I mean, a key to keeping people is to help their development, make sure they're satisfied with the job that they're doing. Could I just ask, I think I understand your transport now, but what I found confusing was the number of what looked like ambulances on the slide. So if they're not ambulances, can I suggest that you indicate somehow that there is a different system? Because the first impression on the slide looks like all of those, I'm sorry, and I have been hearing stories of backed up ambulances at hospitals. So what it looks like is backed up ambulances at hospitals.
That's a very, very good point, actually. Thank you. Because we always struggle with how we illustrate this and make it. So it's meant to illustrate the number in terms of proportions of patients who would attend in an ambulance to Weston. It's not meant to illustrate a queue. So very good point, well made, and we'll think about how we actually illustrate that better in the future. But thank you. Yes, that's not meant to be a queue.
That's okay. And I've just got one other, and I'm sorry.
Yeah,
sorry,
one other's fine.
It was about the your last delivery point. Well, capability to deliver. So deliverability, how long to implement the option, and what the interdependencies. So, well, one of them, we've just mentioned, I'm sure, in the full pathway, but that's the sort of risk bit as far as I can see. All of this, which sounds good, how do we deliver it and when?
I think if I may, Chair, and thank you for that, I think it sort of brings us on to the question that we're going to come on to, as to the option we choose and whether this is substantial variation. Now, you've heard that the proposals we have, we would favour option 2 for the discussion around recruitment, retention and our ability to provide a secure future for Weston. If that wasn't considered a substantial variation, then we are in a position where we would still want to continue with the engagement piece, but that would reduce the amount of time and provide us with an opportunity to get on and recruit to those models. So that is one of those things that we will and discuss today. In terms of the other side of things, we're already doing some of the work, as you've heard, in terms of working with our primary community partners to provide that seamless passage through. In order to deliver and open up, as Councillor Bell said, the opportunities for the elective care, we need to think about how we can start to transfer the appropriate patients to the appropriate places. And that will come about over a matter of time, but can only come about when we can actually release some of the activity and some of the capability in some of the other hospitals. And that in itself is dependent on some of the work that's ongoing that we've already described, that D2A pathway work. So you can see there's a puzzle, there's a list of things that would, in order to occur, would allow us to process and proceed to that point. It's probably allowing us within the next few months to think about the recruitment and the opportunities to deliver that, accepting that we go through the engagement, we continue with the business case to get to the point of delivery. And then we can start to think about the other opportunities in terms of changing the pathways for certain patients bit by bit in order to develop the model that we're getting onto. Recruitment is key, as you've alluded to. Recruitment is key to deliver some of this activity, although as Mark has already described, the nursing force, that workforce is already on site to deliver the care that we're describing.
Thank you.
Can I build on that, if I may, just very quickly say, in terms of timescales, as I say, it does depend on which route we go down, although just to reiterate our commitment to doing full public engagement in any event. If we go down the legal route of the formal consultation, we're looking at, in our timeline of a decision-making business case being approved in December. So we wouldn't be able to start making some of these changes and start to think about the recruitment and changing the models until after then. We have if it was to be a more sort of engagement model of public conversation, then we would be able to divert resources quicker away from some of the assurance hoops that we would have with NHS England. We'd be able to think about recruitment quicker, be able to concentrate on our capital bid preparation and develop rotas and what the NHS called SOPs, or standard operating procedures, so writing down the pathway and the service changes so everyone in the system can be clear on the new model of operation. So we have some different options really in terms of timescale, I think, today.
So that segues quite well. So the question we're being asked here today is it a substantial variation or not? That sounds like a simple question, but it's not one with a simple answer. But firstly, thank you for for your presentation. Thank you for the work that's gone in this, because I think my summary is clearly a huge amount of work's gone in. There's some real positives in there. Option 2, it's certainly, from my own view, I'm more tentatively favourable. Option 1, not really interested in. So we need to make that decision of whether there's substantial variation. So what I'm going to suggest we do is for a quick 5-minute adjournment, just so I can speak to the councillors, because the challenge we've got is we've got 2 options up there, and we've got to make a judgment on whether there's substantial variations. Just a quick question from me. Even if one of these are a substantial variation, you're going to have to go through the full process for both anyway, aren't you?
Well, we have our evaluation meeting for the options tomorrow. So assuming that you're content with the evaluation criteria, the clinicians are meeting tomorrow morning to do the evaluation. And I can't obviously prejudge the outcome of that, but I think you've heard quite clearly that there is a strong consensus among the senior clinicians that option 2 is favourable for all of the reasons we've rehearsed today. So I can't, as I say, give you a guarantee on that, but I think it is it's entirely possible that we will end up with a single option proposal tomorrow once the evaluation has been completed.
Timing is everything, isn't it? Okay, so what I'm going to do is I'm just a very quick 5-minute adjournment with councillors to pin down how we're going to do that, if that's okay. And then we'll come back and we'll do that vote on there. I just need to work out how to do it, and I may need some advice on it. We should be no more than 5 minutes, but that's what I'm going to do, if that's okay. And for those watching at home, are we cutting the stream or are we keeping the stream? We'll mute the audio, so stare at our wonderful carpet, give us feedback, and we'll be back in 5 minutes. everybody. I took longer than 5 minutes, so apologies for that. So us as councillors, we're talking about how we do this, because there are basically two options written down, and technically that's two decisions that we've got to make. So I'm going to propose what we're going to do. It's probably easier if I do that from the chair, and we'll take it from there. So our proposal is that option 1, as it is written down there, on the face of it, that is a substantial variation. So we would recommend that option is dropped, because none of us are really a fan of it. Obviously, we need to phrase that in a way that works for the minutes, but you know what I mean. Option 2, we don't believe is a substantial variation. It's more of an evolution of the service. But what we would ask that you do is in the autumn, or near to the autumn, when you've finished with your engagement events that we absolutely want to happen, you share those results with us. Us as a public hosp, we will also try and engage the public on that too, because we've got that ability to do so. And we would ask that you share the results of the clinical senate and your evaluation panel tomorrow, the results from that and the evidence that you've used as part of that. So that's what we would ask for. So if I was to summarise that, option 1 is a substantial variation, but we would like you to drop it because we're not a fan of it. Option 2 is not a substantial variation, and effectively we would like you to share some more evidence with us, as well as the feedback that you get through your engagement process. So that's the proposal. So I need a seconder, which is Councillor Ros Willis, and then all those in favour, unanimous, so that's sorted. Excellent. So are there any questions on that? I know it's a bit of a convoluted, but we had two options to try and have to do.
Just want to thank you very much for the time that you've taken to consider those options, and to the result of your consultation and your views. Thank you. We'd be very, very honoured to come back and share with you the results of the meeting tomorrow and the engagement, which we will take full engagement over the next over those 2 months over option 2, should that come out tomorrow, as the preferred option, which I think, as Colin has said, I think I would anticipate it will be the case, given the strong views in the room. But thank you very much for your time and consideration. Thank you.
Excellent. So that probably moves us along to the second half of the presentation, which was originally written if either of the options happened around engagement or evaluation. So I suppose it's just about saying, is there anything else you want to add on that the context is different at all?
No, so the evaluation tomorrow will take place with an independent chair, Professor Kant, who's coming to chair that meeting. He's had previous experience in evaluation and did the stroke evaluation criteria. The evaluation criteria that we're using is built on Healthy Western 1, so it's a similar criteria based around deliverability, etc. And that will be, each of those options will be judged tomorrow, and I think are outlined in the pack that you have. And that will be the panel of clinicians from around the region, not just Western itself, who will be making that assessment and judgment.
Excellent, thank you. And the public engagement will still happen. When will that now start?
We will develop a more detailed plan that we'll share with you over the next week or two, if that's okay, Councillor. But we would be looking to start that over the course of May to June.
Okay, so that timeline fits anyway then. Yeah, excellent. Okay, no questions from anybody else then. Oh, go on, Ros. Sorry, Councillor Willis.
Yeah, fine. Just to say, so perhaps in our resolution we had autumn to share. If we're going to have that earlier, then we need that earlier back, if we can, maybe early September, rather than late autumn.
Yeah, I think that's a fair shout. I don't think anyone's going to disagree with me changing a resolution that says autumn or earlier. Anyone disagree with that? No, that's fine. That's evidence. If it arrives earlier, it arrives earlier. I'm not going to cry about that one. Okay, so thank you everybody for this agenda item. So we're going to move. Sorry, make it slightly. We're going to move to the next agenda item, which is the Joint Health and Wellbeing Strategy Action Plan that Matt Lenny you'll lead. I know you need to go, Councillor Parker, so thank you. Cool. I'll be left with 4. That's all I need to be quorate, so thank you.
Okay, thank you, Chair. I'll be quite quick because I appreciate I might be a bit of an anticlimax after the detailed discussion before, but I guess it's a nice another aspect of when we've been talking about particular needs around medicine and high-end medicine. This is the other end of the spectrum where we're looking at building and sustaining good health and well-being in our population. So in terms of the slides, maybe move on to the next slide, please. That'd be great. It's not quite nice, my Chris Whitty moment. So just to confirm what we pulled together last year, and this is very much the combination of a joint effort between a number of partners. This is sponsored by the Health and Wellbeing Board, so by its nature is all of the agencies in North Somerset who can work together to improve health and wellbeing. So that's colleagues in the NHS, that's us in the local authority, very importantly our community and voluntary sector organisations and different institutions. So when we talk about education, when we talk about employment, we talk about housing providers, all of those sorts of organisations. So the vision is very much for us to be able to support people to optimise their health and well-being and lead long, happy and productive lives in thriving communities, importantly building on strengths in a way that reduce inequalities in health. So in terms of our guiding principle, it is about improving health and well-being, but in a way that will close the gap for those who are currently suffering the poorest health outcomes and the biggest impacts on their lives. So within that, in the 3 circles on the side there, you can see we've got 3 key themes within the strategy, which is about prevention, early intervention and thriving communities. And most of the activity is then described in that way. And we also developed a number of guiding principles to make sure that the strategy and the action plan that will take this forward sees the difficulties and the opportunities in a certain way. So one is around partnerships and collaboration, both in the development and the implementation of the strategy, tackling inequalities I've already mentioned, also about place-based approach. So this is trying to get the solutions as close to people as possible, whether that's, some will be North Somerset level, some will be collaborating across the whole of BNSSG, some will be at the integrated care partnerships or locality partnerships as they'll now be called level, so one Weston and Woodspring, and then so very much at sort of street or community level where you will be able to identify and work on solutions. We're taking the life course approach, which is reflected in the last presentation, so starting well, living well and aging well, because good health and well-being should be something that we enjoy throughout our life. We're very much using data, insight and learning, so looking at what the data is telling us about need in our population. And that's both quantitative and qualitative information, so looking at lived experience as well as data indicating perhaps where cases of obesity or more fundamental factors around wider determinants like access to good housing or access to open space. And empowering communities. So throughout the strategy is about working with our communities and seeing the solutions coming from there rather than just a kind of either an organisational or a medical model of health. This is much more about a social collaboration to try and improve health and well-being. So moving on to the next slide. This is a pictorial version of the whole thing. So in our world where people are enjoying long, happy and fulfilling lives, what we have within the overall area there is the principles, the 6 principles across the top of the sort of building structure there. And within that, there are areas of focus. So these are the things that tend to drive poor health and poor health outcomes. So we've got mental health there, mental health and well-being, levels of physical activity, people's food and the nutrition that they get from that food, tobacco use, substance misuse and alcohol use. Those tend to be the drivers of the main conditions. If you think about, we're hearing about cancer, we've been hearing about cardiovascular disease, those will be the things that will most impact on the outcomes for people, which will then present in models of treatment. And then thinking outside of that, it is about the wider determinants of health. So what does a good education, what does good start in life for babies and young children have? What's the benefit of having social connections in your life? It's those sorts of issues we're looking at. And at the top of that there, what we have used throughout the strategy is a framework which was developed by Public Health England, which is now Department of Health and Social Care. And it's called the Population Intervention Triangle. So it's recognising that we need to keep things in balance. So we have certain types of civic interventions, which tends to be where the council leads, and town and parish councils as well, and any other sort of civic organisations. We have services to one side, which are the things that respond to particular elements of need, whether those are at low levels or more acute need. But it's also about community, and unless we understand community needs, community preferences, community opportunities, we tend to design things in a slightly remote way. and they don't quite connect with those communities and don't serve them appropriately. So that's just to talk you through the representation there. If we go to the next slide, please. So what we did do alongside the development of the strategy was to have a very clear action plan, which worked across those three themes of prevention, early intervention and thriving communities. It's a 3-year strategy, so it's already been implemented in part during 21-22. We've got further implementation in this financial year and the next financial year. And in terms of the actions that we identified for last year, so we're pulling together the final bits of reporting now because we've got to get Q4 in here, so this is almost Q3 rather than Q4. So the 56% of actions which are green hopefully will stay green and complete. Similarly, for the 33% which are amber or amber green, we'll push into the green status, so we'll finish off the things that we said we were going to do. And there are some areas where we had ambitions, but because of some impacts around COVID in terms of staff availability and also recruitment into some roles, that's had some impact on about 1 in 10 of the actions which we set out. But those will be carried forward into this financial year, so we will still stick with the same plan, just to give assurance on that. So what we have developed alongside the action plan is a public dashboard which goes through in detail each of the objectives that we've set ourselves and progress measures against that. Now, I'm not going to go through that in great detail now, but it is there for people to have a look at and to play with a little bit. We are building up the bank of information within that, so some areas have very good measurements in them already. Say, for example, the National Child Measurement Programme, which weighs and measures children in reception in Year 6. We've got a long bank of data to tell us where are the hotspots in North Somerset in terms of the poorest outcomes for children, which tend to almost exclusively track areas of deprivation, like lots of other indicators. But for other things where we're trying to measure improvements, for example, in health and well-being amongst different population groups, those national measures are less available. So we're having to develop some of those measures, either based on user experience of local interventions or extrapolating other national data. So it is a bit of a building up the picture to go alongside the action plan as we go. But what we thought it might be helpful to do is just pick out a couple of areas to give a bit of an illustration of some of the progress that we've made and some of the initiatives that have been started through the development of the strategy. So the two we've picked out is mental health and well-being, and food nutrition and food insecurity as two areas which are fundamental drivers of people's health and well-being. So just moving on to the next slide. So just a kind of quick recognition of need in our population. So the high level of adults who are reporting an anxiety score, important to recognise that we have had an increase during the pandemic. It's a question of watching that trend over a period of time, whether there is a natural fallback down or whether there are some fundamental issues that still need to be addressed. High score around things like depression as well. So, we've got a big burden of need in our population, both at adults and at children level as well, which again, some indications that COVID may have exacerbated that, partly through some of the stressful situations people have been in, but for children, the interruption to education has been quite a significant impact. So there are a number of things we need to work at. So we already had a big challenge, but we've got some additional challenges to work through. And then when you look at unhealthy weight as a driver of poor health, it's approximately 2 in 3 adults are on unhealthy weight, either overweight or obese. And about a third of children, by the time they go into secondary school or leave primary school, are also overweight or obese. So that's a significant challenge for us. And we need to work with our population to try and shift people's opportunities to change those outcomes. It's not just about individual behaviours, I'd really like to emphasise that. This is about the support and the system and the environment that people live in and the daily cues and opportunities they have to strike the right balance between physical activity and a good diet. The other point in there about unhealthy weight, so I've mentioned that around the National Child Measurement Programme, and it would be the same around mental health. What we're looking at in terms of inequalities is a much greater burden of need in those areas where particularly income and other challenges are the greatest. So just moving on to the next slide, please. So just to give an idea of the sorts of objectives we've put in around mental health, And there's more detail in the full dashboard, which gives a detail of the full response. But essentially what we're looking to do is to improve people's reported mental well-being, to also pick up emotional well-being, to try and make sure that we're improving people's access to timely support. And we've seen some additional services grow over recent months and years to try and address that growing need. And also one of the big areas is to reduce social isolation, particularly in communities for older people, which is a big driver of poor mental health. So what we have done in our 21-22 action plan, so we've done a needs assessment around adults. We're just completing this similar piece of work around children so that we can use that information to drive forward what the recommendations would be in terms of local needs and how we're going to meet those gaps. We've got a meeting of a multi-agency mental health strategy group happening next month to pull together the findings of those needs assessments and to develop a specific action plan. We've also been doing some immediate work around community grants, both for adults and children. So this is to offer more opportunities for people to access support in their local community. There's a bit more detail in the paper itself that accompanies the slides, which I won't go through all of that now, but it's very much been a process of inviting and working with local organisations to develop those opportunities for people to improve their outcomes. Same around social prescribing destinations. So what we have had in the last couple of years is a real growth in the numbers of social prescribing opportunities, either through primary care, through work around social care, through community organisations. And as well as that recognition that we want more people to not be put down a medical path if that's what they don't need, we also need places for people to go to get some practical support. So some of those grant areas are trying to fill that gap, and there's the ambition to do more over the subsequent years of the action plan. It's also thinking about settings. So one of the areas we're developing at the moment is a healthy workplace award approach. So that's about trying to build an environment which encourages health-enhancing behaviours. So that will be around things like mental health support, but it will also pick up areas like physical activity to and from work. It'll pick up areas like food availability in work and support around changes around diet and lifestyle, and importantly around tobacco use as well. So we'll continue that drive to support people to stop smoking as the biggest cause of ill health and inequalities in our society. And also in a schools context, this is working with NHS England, the new mental health support teams that are going to go in to provide a greater level of support in a school context. That's going to help. There is a huge burden of need there, so I'm not going to pretend it's going to solve the problem, but it is trying to work across different agencies and different programs to show how we're going to systematically try and address some of these challenges. So maybe just moving on to the next slide. This is a bit more about the food. So I've talked about trying to address the issue of unhealthy weight in children, talked about adults as well, and then the focus on particular communities at ward level, and food insecurity. So we've got these two kind of slightly strange but coexisting dynamics of too much food in terms of too much of the wrong type of food that can drive obesity, and at the same time people living with real insecurity and worry about what food they can provide for their families. So it's quite a difficult communication challenge to talk about food in a way that doesn't alienate one or the other, and get back into, well, what does it mean for you in your daily life, and how can we support you in the context that you're in? I think that's really important. But again, talking about settings, so back to the Sir Michael Marmot principles of the biggest things you can do for health inequalities is what you can do at the earliest stage of life. So we're working with our early year settings, so our nurseries and our early years providers to try and develop an award scheme so that they can systematically improve the practice that they have within their settings, but also work with the parents and work with the kids to understand and enjoy food within that environment as well. We've also got some additional brief interventions for children as identified as an unhealthy weight, so that's working with our school nursing provider, Serona, to develop some of those, so they're the ones doing the weighing and measuring. It's about, so now we've defined the problem, what more can we do to actually try and intervene and try and address it? We've got some weight management support for adults as well, so as well as the commissioning of Slimming World to provide. We've also got some specific modules for men, because we do know that that as an intervention isn't particularly popular with most men, so we need to offer a slightly different solution. And also working with our colleagues in peer health. So again, this is emphasising the collaboration between agencies. So peer health wanted to do some more work in terms of support, in terms of people's health and well-being. So rather than develop their own service, they came to us and they've commissioned us to provide additional health trainers in and around Weston-super-Mare. So we've been able to combine our resources and have a one service for access both through the sort of public health routes and the local authority routes and through primary care as well. So we'll be able to work much closer together in identifying what's happening with those services and develop more solutions. So that's a quick tour of that. And then on the next slide, it's just showing that we're doing other things as well. So we've got community food grants that have gone out at the moment. So that's around the sort of day-to-day skills, around cooking skills, about understanding food, sustainable, affordable food, affordable being really important in the context that we're in at the moment in terms of some of the income challenges facing families. There's also work with existing organisations, Food Alliance, so this is about sustainable places. This is also about growing and eating your own food, as well as purchasing the food that will benefit your health most. Food resilience pathway, so that's things like the community fridge in Weston-super-Mare, holiday activity for kids as well, because we do know that when kids are out of school, that can be a real risk area in terms of accessing food in a most basic sense, but also accessing healthy food as much as possible. And then also picking up on the point about collaboration sometimes isn't just at the local level, it's at the bigger level. So that was about a bid that went in across BNSSG to try and develop solutions in communities where there are the biggest challenges. So for us in North Somerset, it's around the Bournemouth and Central wards. Those are the two areas where those interventions will be prioritised. So maybe just moving on to the next slide. So as I say, we're going to be constantly monitoring how we're implementing the action plan. That's going to be publicly available. It's on the website, so you can play with the data a little bit, and if you've got more questions on that, I'm happy to take those. We're also trying to develop the data itself, which picks up on the points I made earlier about service level data, qualitative reports, all of those sorts of things. And it will evolve over time. And actually, if people have ideas, either through your own community networks or through organisations that you're part of additional measures and things that we would like to put in the recording of how we're doing on this, then very happy to take those suggestions. Maybe just move on to the next slide. So that's an example of what it looks like. It looks a bit dry, but actually when you get underneath it and you start to realise some of the things that develop. So that's the example of healthy weight at ward level, where we do have some data there which can give us a bit more of a trend graph. Where are we going? You can see in the bottom right-hand corner there. But under each of the objectives, what we have there is measures, and then each quarter we'll be reporting on what's happened in terms of activity and what the overall status is, which thankfully for that one was green, so that was a good example to choose. Maybe move on to the next one. So what we also have at the moment, so this is very welcome. So initially when we set up the action plan, we pulled together investment from within the public health budget. So we've identified £500,000 worth of service areas to dedicate towards the delivery of the action plan. Plus we created a £500,000 investment pot for the lifetime of the strategy over the 3 years. So I'm really pleased to say that that £1 million kind of council-led investment has now been matched by colleagues in the CCG. So what we have now is a new fund to be able to do additional investment in the health and wellbeing strategy. And what we have at the moment is a process of asking for people to come forward with proposals that will match the ambitions set out in the action plan. And we're going to go through a process of reviewing those, taking it to a stakeholder workshop on the 5th of May, which is the refresh of the health and wellbeing strategy, because when we set it, we said we do an annual kind of review of how is it going, is it focused on the right things? And that will include some discussion about where we could invest that money most appropriately. Then we'll do some more options appraisal, and then eventually it will come back to the Health and Wellbeing Board at the meeting on the 29th of June to agree that investment profile for that new money. And that will have the emphasis on prevention, early intervention and thriving communities. So we'll complement the work that's been done in services to try and provide the right type of support to people at the right time. So the more we can do to slow down the tap or even switch it off, the even better it is in terms of them being able to manage that need for more medical interventions. The other thing I'd mention here as well, in terms of the health and wellbeing strategy itself, I'm pleased to say that we've been shortlisted for 2 national awards on the work we've done on this, both by the Municipal Journal and the Local Government Chronicle, so the 2 kind of major local authority publications. So we've been shortlisted. We've done 1 pitch. We've got another pitch to go, and then we'll see how we go in. I think it's in late June when we get the result. But it's a good chance for me to pay tribute to my colleagues who have done all the hard work on this. I'll mention particularly Georgie MacArthur, Charlotte Cadwallader in the public health team, but we've got a steering group that have developed the strategy and lots of people who've been massively enthusiastic throughout this from a range of organisations. I think of colleagues in primary care, I think of colleagues in community services, and indeed, you know, we've talked more about working more with the acute sector as well, so what can we do more of? Tertiary prevention, to make sure we can maximise the opportunity to get people as fit and healthy as possible for as long as possible in their lives, and happily see them thriving in their own community rather than needing any service. So that's a bit of context. Maybe just move on to the next slide, which is just really asking for some view. So this is to make sure this is visible to HOSP, hopefully to give you some assurance that the process has started, we've delivered the strategy, the action plan is in progress, and we've got ambitions to push that further and faster over the next few months. But any observations, any ideas about other things you'd like to know about? I'm very happy to take those questions now.
Perfect, thank you. And just to start by congratulating your team on the shortlist for those 2 awards. I mean, I think that recognises all the hard work that's gone in. Do any councillors have questions? So, Councillor Ross-Willis, and then I'll jump to you after.
Just a very quick one. Stakeholder workshop, who is that likely to be? What are you aiming at for that, if I could just...
Yeah, so it's primarily the Health and Wellbeing Board, and the chairs of the overview and scrutiny panels have been invited as well. We've also got representation from colleagues in health service, different parts, the integrated care partnership, so Western and Woodspring, and we've got voluntary community sector representation there. So it's a bit of a broad church of people to talk through where are we at, what do we need to do next, and how might we prioritise our actions moving forward, if that helps.
Just a quick one on that. I mean, I was just wondering, because of the eating side and the food side, whether, you know, community meals or something to be included in that. You know, it might be a thought, or one of the other providers or something like that.
Yeah, so we've got certainly representation from colleagues in social care who'll be coming along and talking about different services that they'll provide, which would include community meals, but other aspects of support for vulnerable adults and children as well.
Andrew, did you want to come in quickly?
No, thank you, Chair. Just through this very, very interesting presentation, so thank you very much. I mean, personally, I'd like to explore your BI in your dashboard, because that looks very good. Mark's just come up with a question, a query, a suggestion, because clearly working with secondary care, we'd very much like to involve ourselves with that with you. Mark, do you want to...
Yeah, funnily, as you were discussing, I approached a note to Andy. So there's what was the staff nursery, which is a place on site which we're exploring what we could utilise for that space. So I'd be interested to whether there's opportunities to explore sort of collaborative working in terms of some of the things you've talked about, workforce and well-being and things like that as well. So we've got a well-being lead, so we'd certainly be very interested to see if there's anything we could. I can't promise the space at the moment; it's a bit above my pay grade, but we are looking at what we can use that space for, which is actually on site. So I think some of the things you've discussed might be interesting to continue to explore together, if that's an opportunity.
Yeah, I'd be delighted to do that, and so maybe we'll set up a separate meeting. I mean, it's interesting as well because we commission services on the site. So the sexual health service is public health commissioned. That's an aspect of supporting health and wellbeing in the community, and there's lots of opportunity there to think about working with clinicians, and as a setting and as a workforce, it's a huge part of our community. So the more we can do together to to maximise those opportunities would be great. So yeah, happy to follow that up.
So, Councillor Hafson, you've got a question, and then just a warning, we've got Councillor James going to beam in and ask his question.
Comment and question. The first comment is one of my parishes, I was very impressed because they applied for one of your grants and I believe they got them. And I was really impressed by the approach because it sort of included healthy cooking and growing your own food. And I added a suggestion of actually including foraging as well, which I think will actually be quite fun for children. And I think it's really important that you actually make things fun and not just healthy. I think that should be a really major emphasis. So I really support that. The other thing is quite much more sort of detailed. And you mentioned the healthy working environment. And I'm sure you're aware that Indy Sage has asked employers to sign a pledge to be a healthy employer in terms of pandemics. And I was wondering whether that has been considered, because it's mainly to do with ventilation, basically, in the workplace, and maintaining that into the future, where it's not legally obligeable anymore, but I think it's actually a really important step forward into the future.
Yes, just on that point about healthy employers. So yeah, we've got health protection as one of the areas to review. So in its broadest sense of around environmental factors as well as disease prevention. So that is one of the things in the criteria, as is other things. We're trying to innovate a bit more. So thinking about our population. So we things like people often get money clinics before they retire, don't they, in terms of what to do with your pension. What we don't get enough of is how to plan for your life when you're not in work, and what are the things you can do to promote a healthy, active lifestyle, a social connection, all of those sorts of things. So there are a number of things where we are trying to, so we're in the pilot phase at the moment, so working with some organisations to test out how we can create a final criteria that will work really well for workplaces and be flexible enough depending on the size of the employer, because we've got a range of large employers and some really quite small enterprises in here. But no, I take your point about it's providing practical support and advice and getting people to commit to certain environmental factors that will benefit their staff.
All right, we're going to attempt to beam Councillor Hugh James in through the magic of technology. Oh, hello, we can see you.
Bro, hopefully this will work. My camera's, my laptop's video card's broken during this meeting, so hopefully this works. Yeah, really good policy, and it's great to see you're getting national recognition for it. I'm a big believer in sort of, if we are doing any initiatives, trying to use existing communities of practice. And it's great that, groups, clubs, and it's great that we're doing that. I'm really interested in the Healthy Workplace programme. It was sort of mentioned during this, but if any information outside this meeting would be really useful. I noticed you've got 6 employees recruited so far. There's some massive keystone employees in North Somerset. It would be great to hear if you're working with the economy team and how that's sort of being done. I know as a people operations person myself, as an employer, there are about 50 different mental health initiatives, and it can be a bit daunting. When do I actually join with? So it'll be useful to actually see what in practice does it work against or with all these sort of different initiatives that employers need to juggle. Does it create an extra bit of work, or does it really add value to our local workforces? Just to sort of, I imagine you already know, but we now have a mental health champion within North Somerset Council, which I think is Mike Solomon. So I'll be interested to see sort of what role the mental health champion as a councillor has to sort of be an ambassador for all this work, and what they can sort of do for outreach. In terms of social prescribing, my parents have been involved in gardening, social prescribing, and all the stuff that's been coming out, and really getting people to go outdoors regularly, getting out of the house, that sort of thing can make a huge difference. It's great to see that sort of stuff going on, which is sort of linked into the food poverty. Due to the inflation in food costs recently, it can be a lot of people I know who are more struggling with money are really struggling to access just fresh fruit and veg. So hopefully the Western fridge might be able to do something to fix that. I know there's a Portishead fridge coming in, but anything that we can do within our work just to make sure that people can continue to access fresh fruit and veg, I think is really important. And I'm glad that you covered how difficult getting the messaging is right on obesity and healthy eating, because whilst obesity levels are going high, there's also really high levels of anorexia within the North Somerset Council area. So I'm trying to make sure that messaging to do with one doesn't really add against the message against the other when we do outreach. It's just really important. Cheers. I know that was sort of whistle stop tour, but I am here listening.
Thank you, that came across fine.
Thank you for that. And on the healthy workplace, I'm very happy to provide some more information on that so that you can see a bit more of the detail, but it is meant to be a support to workplaces, not a burden. It is meant to be a workable solution depending on the size of the organisation. And we do provide some active support, so we help people to do the kind of baseline assessment to work out where they are, what are the things they'd most like to work on in terms of workforce, and build it up from there. Because often it's not trying to do it all at once, but it might be that, for example, I don't know, people on site would particularly like to know more about how they could get into active travel a bit more. So you use that as your start point because there's a natural interest, and then from there you might be able to sort of move on to other topic areas. So it's a kind of test and learn approach in this pilot phase, but we can definitely bring some more, or we could bring a particular report back to OSP if that was useful at some point later on.
Cracking. That'll be really good. Thank you.
Excellent. Any questions from anybody else? I might stand back from the microphone a bit. So my question really was just around a joint action plan like this involves many partners. I suppose we're at the early stages, but do you feel you're getting the buy-in from all the partners you need? Are there any partners that are missing that we're not quite getting hold of?
Well, I think hopefully when I was talking through some of the main areas of the plan, I was almost cross-checking people off as I was going along. So actually, to be fair, there has been a lot of enthusiasm. I think some of that is the way we built the strategy. So rather than having a sort of, I'll tell you what the plan is and what the solution is, it's allowed room for people to come up with ideas. And similarly now with the bids that have come through, it's sort of ground up rather than top down. Particularly when we talk about solutions, because you know, in public health we're the worst at it. We can describe a problem to the nth degree, but that doesn't necessarily move you on. You have to then think about, well, how do you apply that in practice? And that has come through the collaboration between people. So in the steering group, we've had the broad representation. And what's been interesting is watching people kind of bounce off each other and increase more understanding of what health and well-being might mean in their context as opposed to somebody else's. So I think this is about a culture change as well as a plan and a strategy. It's about seeing this as everybody's business. And to be fair, so far we've had good engagement, and I think we'll get more. And as we do more around the action plan, we'll try and record more of that to try and talk about the range of people who have got involved, and credit where it's due, because it's the activity that happens out there rather than in the strategy that makes the difference.
Excellent, thank you. And just well done on sharing the data on the public website. I'm all for transparency, and if you're working with loads of partners, that's where they're going to get their data from, so that's really helpful. That's a bit of a filibuster in case anybody else wanted to ask a question, but they don't. So thank you for that, Matt. The report's just for noting, so we don't need to vote on anything. So that brings us then to the last item, which is item 8, which is the work plan. And I'll do the world's quickest run through on that, really. So just to update people, so on particularly the working groups that there were. So the Western Primary Care Estate Review, that could pretty much be closed now because that plan has been submitted and it's going through the planning process. I'm not planning, it's out of my hands, so we can close that working group. The working group looking at children's mental health services between SIPs, which is Children and Young People Scrutiny, and HOSP, that's finished, but the report is going through internal governance, so that will be dealt with at the Children's Young Persons panel in June, probably, and then we'll report back to here in June. I don't know who's first. Ours is the 23rd of June, so we'll work out which one's first, but it will come back to SIPs. And finally, just to say, the merger integration working group is still ongoing. We've met twice. We meet tomorrow. So that's a note for everybody's diary. And we'll give an update here once we're nearing the end of that. But I would say there's been a lot of positive stuff we've heard around staffing and recruitment. But I think there's probably one or two more of those meetings, and then we'll report back to here. But councillors are more than welcome to attend. They have the invite should they want it. So that's the working stuff. The next HOSP is June. We obviously have dentistry on there because they couldn't come today. and there'll probably be a couple other things, but is there anything anyone wants to note or feedback on any of the work plan? Go on, Councillor Ross-Willis.
Yeah, maybe only just make sure we put on the work plan from our resolution today, because it'd be in the minutes, but just pop it on.
Yeah, that'll be on there, don't worry. Right, so silence. So in that case, that's all of the agenda items. So thank you all for today. I know it's been a fairly long meeting. I know it feels a bit weird being in a pretty empty room, but obviously people will watch this back as well. So thank you all. Our next HOSP is 23rd of June, I think, from memory. So we'll pick it up then. Thank you.